This module will be going over communication in EMS. So our objectives here are to describe the components of the communication process, including some things that can interfere with effective communication, identify the impact of nonverbal behaviors on communication, describe effective communications that help promote safety in patient care, explain the importance of establishing a rapport with the patients and their families using therapeutic communication, as well as giving examples of an appropriate use of therapeutic communication. And then, of course, analyzing your own communication to avoid common pitfalls. So with communication, it's not possible to perform your role as an EMS provider, as an EMT and advanced EMT paramedic without communication and teamwork. They're both super important. You can't really have teamwork without that communication aspect. So it's important to make sure that you understand the different specialized EMS communication equipment, the stuff that's discussed in the EMS systems communication, as well as a lot of different factors that have an impact on your communication, like your environment. Is it a loud area? Is it very quiet? Some sender and receiver impacts as well. We'll talk about the characteristics of both of those. The message. Have you ever heard the term a picture's worth 1,000 words? You know, that sometimes actions can kind of fall into that as well. So even if you are saying all the right things, if you are not sending out the right physical, body, or nonverbal clues to that patient, then it kind of undermines whatever it is that you're saying. And then, of course, whatever channel or medium that you are using. Our sender characteristics are going to be things that help us establish credibility, because we are in a very unique position. We've got to go into a residence or a location, be introduced to a patient or a person, and then within just a few minutes we have to get them to trust us implicitly that whatever drug or procedure we're about to perform on them is needed and is going to help, and that we're not going to kill them. That's a very important role. We also have to be able to get them to trust us with sometimes their almost deepest, darkest secrets, their medical history and personal information that typically we don't feel comfortable giving to strangers. So establishing that credibility from the get-go is really important. Trustworthiness kind of goes with your credibility, but you've got to have the wherewithal, the air about you that you are trustworthy. And part of that is looking and acting professional. And the big part of that is requiring effective communication. If you walk in and you don't know how to speak to somebody, they're not going to implicitly trust you. They're not going to be a willing participant, if you will, in their care. Receiver characteristics. This is all things about how the person is going to react to your message that you're talking to, because your message is whatever we're doing or whatever we are saying. There's a lot that goes into this that we have no control over, so it's just important to be able to recognize it. But things like intelligence. Somebody who is highly intelligent can probably comprehend a lot more with depth and understanding than somebody who is not highly intelligent. Kids versus adults. A kid may not have all of the experience, or a kid will not have all the experience that an adult has. They don't have anything a base to compare whatever the problem is to. Self-esteem is another thing. If you have somebody who doesn't believe that they are worthwhile, then they may not feel they deserve your help. And it's important to make sure that they know that everybody deserves the help and the care. Important thing here is just to realize that there are different qualities of your patients that may kind of hamper or impede sometimes your communication. We have to be able to recognize those and learn how to work around those. Now, the information is whatever we're talking about. So we've got to make sure that we are exchanging this information in a way that both people understand. For example, if you have a child, a 3-year-old toddler, and if you need to find out if their stomach hurts, if you look at them and you say, "Does your abdomen hurt?" they're going to not understand a thing you're saying. They don't get it. So you may have to adjust what you're saying. For instance, you might say, "Does your tummy hurt?" or "Can you show me where your tummy hurts?" They're more likely to understand tummy or other age-appropriate descriptions that everybody can understand there. Interference is anything that interferes or gets in the way of this communication. Some things you can control, like how loud your radio is, or whether you're listening to them or listening to somebody else, or whether you're doing other things while you're trying to listen to them. And then there's other things that are beyond your control, like if the patient has poor hearing, you can't control that. If there's environmental noise, sometimes you can control it, sometimes you can't. Some things you might do is ask others around to step back a little bit, give you a little more room if they're too loud in the environment, or if you are just in a loud, noisy place that you can't stop the noise. Maybe the best interest is to get them out of that environment and into a quieter ambulance or a quieter space like the back of your ambulance. Some other things that could potentially provide some interference are things like cultural differences, language barriers, things like that. So it's real important when we are doing this communication. There's several things that you need to make sure that you are doing to effectively communicate. You want to make sure that you introduce yourself at the beginning of any conversation. Always introduce yourself, and I like to tell them my level. So for example, I would introduce myself as Jessica. I'm a paramedic with ABC agency. What can I do for you today? Right, you want to make sure that you keep eye contact or make eye contact as appropriate. Now, it is important. Some cultures, eye contact is considered a challenge, or other cultures, it's considered rude. For the most part here, it's considered to be rude not to make eye contact at all at any point. Whenever it's practical and safe, make sure you position yourself at or lower than the patient. So that way you're not towering over them, speaking to the top of their head, that you're be able to look them in the face and get on the same level with them, both figuratively and literally. Make sure that you're using that language, like we said earlier, that the patient can understand. You typically want to avoid any kind of medical jargon or anything like that. Be honest with the patient. Y'all, people can tell if you are lying. I don't care how good of a poker face you are. Most patients will be able to tell if you're lying, especially kids. Don't lie to them. Be aware of your own body language. If you have little tics or habits, you may want to try to work on those, so that way you're not doing things to distract from the patient. Make sure that you're not closing yourself off for the patient where they think, oh, well, they're not interested at all, so what's the point in talking to them? Make sure that you speak calmly, clearly, and distinctly. I have a tendency to talk kind of quickly, so I make it a point to slow down and try to speak a little more clearly so that way they can understand me. Not necessarily loudly, though. If a patient does have difficulty hearing, you may want to speak clearly with your lips visible, and you may want to alter your tone a little bit, maybe a little bit lower voice. Some people, usually the first tones to go are the higher pitched tones, but you don't necessarily want to yell or speak much louder. Just clearly. Don't overpronunciate your words. As far as addressing your patients, make sure that you are using their proper name, first or last, depending on the circumstances. More formal situation, I use Mr. or Ms., whatever their last name is. If I say, hey, Miss Smith, what's going on today? And she says, oh, please call me Betty. All right, Miss Betty, what can I do for you today? You just adjust it to whatever they request. Don't call them sweetie. Don't call them baby, darling, or any of that. I know in the South people have a tendency to these euphemisms and pet names. Don't do it. Some people may find it, and if they tell you to call them sweetie, then by all means call them sweetie. But if they don't, it just comes across as kind of creepy. Don't do it. And then lastly, make sure that you're giving patients enough time to answer a question before you fire off another one, because some patients will get confused fairly easily. So if you send out 5 messages, if you send out 5 questions real fast, like, they're not going to know which ones to answer first, or they may even forget by the time you get to the last one. So make sure that you're just giving them one at a time, give them the opportunity to answer before you move on to the next thing. Now, if you need to use an interpreter, whether it's for sign language or another language, talk to the patients. Don't say ask them da 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 da. Talk to the patient, and that interpreter will interpret your exact wording to that patient. So make sure that you're talking to them. Now, with team dynamics, a team we know is a group of individuals with some common goals. In EMS, our common goal hopefully is to get that patient to the appropriate care and be an advocate for that patient. So it's important that we have an understanding of that goal, but also to know our roles within that team dynamic. In order to do that, you have to have effective communication. Now, as an advanced EMT, there's a very good possibility you may be in charge, if you will, on a truck one day. It may be you and, say, an EMT, and you are the highest level of care. You can't assume that your partner, the EMT, can read your mind. they can't do it. You've got to be able to be clear with them. You've got to be able to let them know what you need from them. Don't be afraid to ask for help, but don't be barking out orders either. For therapeutic communications, there are a lot of difficulties that can occur here that can make this much more difficult than it should be or could be. A lot of things are like the age-appropriate questions or answers or stages of development or patients with special needs. So you just kind of have to figure out where is this patient and what's the best way to try to communicate with them. You may have to look at different cultures, okay? You have to recognize any preconceived stereotypes that you may hold and realize that not everybody's the same, and there are different ethnicities, there are different cultural things that make a difference in how we approach. Space is a big thing with a lot of different cultures. You've got several different kind of zones. You've got your intimate zone, and those are the people that you can stand right up next to, or that you give hugs to, or things of that nature, who can get right in your bubble, if you will. And then you got your personal distance. This is for people that you may be familiar with, that you are a friend or maybe an acquaintance. But this is, for me, my bubble for the personal distance is usually about 2 feet. So if a student comes and talks to me, I don't like them to be any closer than 2 feet to me. That's just not in my bubble. I don't like it. For your social distance, for your people that you know socially or see out and about or say hey to in Walmart or wherever, usually this is about 3 to 4 feet or so. And then, of course, your public distance for random strangers, this is your big bubble. For me, this is like the line at Walmart. I don't want to be able to, shrug my shoulders and touch you like you're too close. Back up, you're in my bubble. So realizing that people have bubbles, and these bubble sizes vary, kind of come in slow and gauge how they're responding. And that's another reason why you want to get down to their level and not just crowd over them. It can make some people very, very uncomfortable. As far as your touch, some people are touchers. I'm a toucher. I'm a hugger. Not everybody is. So, invited touch. If somebody wants to hold your hand, then let them initiate that. If somebody wants a pat on the shoulder, then that's fine. But don't put your hands on people in context of comfort or anything like that unless they have asked for it or made it clear that they are okay with it. Now, our key points that we really want to make sure with our therapeutic communications, make sure that we are able to communicate with our patients effectively. Make sure that we are speaking calmly, clearly, with a non-aggressive tone. Make sure that we're showing courtesy and compassion. We're using appropriate surnames, okay, that we're addressing and dealing with the best we can any cultural issues. We want to make sure that we're controlling that environment. We discussed it briefly, but we want to make sure that we're providing privacy. Nobody wants to share all their business in the middle of a crowded mall food court. Make sure that you're giving room to where they feel comfortable sharing this information or having these exams or procedures performed. And try to control the noise if at all possible. You want to make sure that you're in a place where you can hear the patient speak to you and you can assess the patient and hear the patient as well. With your nonverbal communication, your posture, your gestures, facial expressions make a big difference here. Think about that personal space there we talked about. Think about how you're standing. If you see somebody with their fist clenched and their jaw kind of clenched, the first thing I generally think of is that they're angry. So if you are a fist clencher, think about that. If you seem angry that you're there at this patient and you had to go on a run, is that patient going to trust you? Probably not. Verbal communication is really important. Several different interviewing techniques and procedures that you will use in among the top 2 are going to be your verbal communications and your nonverbal. So we talked about the nonverbal, but your verbal communications, there's a couple of aspects that we really want to make sure that we are using and utilizing to get the most effective evaluation of our patients. So we'll make sure that we're actively listening. If you come to me and you're asking me questions and I'm sitting here typing or reading a book or reading something on my computer or answering a text on my phone, you're not going to believe that I'm actually genuinely listening to you, and you're probably right. So make sure when you are talking to your patients, you have to actually listen to the answers, listen to them. Even if you don't care, listen to them and be available. Be there listening to them. Don't be giving orders, doing other things if at all possible. All right, you want to make sure that you are using a kind of a mix of questions. It depends on each individual situation, but your open-ended questions, these don't have a limited range of options. So this might be like, why did you call us today? Or, how are you feeling? Whereas closed-ended questions, or what kind of medical problems do you have? Closed-ended questions has a little narrower expected response. So this might be, does your chest hurt? Yes or no, right? Do you feel ill? Yes or no? Little things like that, where those are good for either people who don't speak very well or who may not be able to comprehend multiple parts, or if you get somebody who's a rambler, you can kind of rein them in on that a little bit. Leading questions are going to be suggesting answers to patients. These are kind of good sometimes if they don't really know how to describe it. So I might use this in like a chest pain. So if I'm like, what does your chest pain feel like? And they're like, and they're having trouble kind of finding the words. Well, is it sharp, stabbing like a knife? Does it feel like heavy, like there's something sitting on your chest? Does it feel really dull or achy? Think different things like that, and kind of give them some examples to see if any of those might elicit a response. Always make sure that you check your understanding by interjecting and asking questions. All right, so you're saying that your stomach's been hurting for 3 days, correct? All right. And by doing that, you're clarifying your information. Now, if they're doing something or saying something that doesn't make sense or it's inconsistent, point it out. All right, confrontation is not always the most appropriate, but does have a place. You may need to remind them of what they've said. Facilitation is just kind of, okay, encouraging them to continue on. Reflection sometimes is silence, sometimes is repeating what they've said to make sure that it is in fact what you understood. Silence can be a lot. You'd be amazed. People feel the need to fill the silence. I do the same thing. If somebody's quiet, I start talking. So you sometimes, just by letting them, give them that pause and letting them have that silence, sometimes you'll even get even more information than you were anticipating. And then you want to make sure that you are summarizing so that you kind of sum it all up, make sure you got all the important highlights. So this also gives them the opportunity to make sure you were listening, but also if they forgot something, to bring it up at that point before you move any further. Some of our pitfalls that we will encounter in communications are going to be things like multitasking. If you're trying to take a blood pressure and asking them questions, you're not going to do both of them well. You're going to slack up on one of them. So make sure that you pay attention to what you're doing and don't try to do too much at one time. Utilize your partner or other people and have them do some things for you as well. All right. Overloading the patients with information or questions, giving advice and opinions. Sometimes our advice is warranted, sometimes it's not needed. Sometimes your opinion is your opinion, keep it to yourself, unless they specifically ask for it. If a patient's telling you something and you start changing the subject or interrupting, that can be problematic as well, because then they didn't get to finish whatever they were saying. You could distract them, they could forget something important. For your special patient communications, things like your age-related characteristics and things like that. Like I said earlier, the older you get, the more likely you are to need some assistance in hearing things or something like that. Little kids have a difficulty understanding at an adult speaking level what's going on or being able to describe it. They may lack the words to be able to describe what they're feeling. If they have sensory deficits, if you have somebody who cannot hear, you're going to have to overcome that. If you have somebody who cannot see, you're going to have to overcome that. So you can't just go up and put a blood pressure cuff on their arm because somebody who could see you knows you're coming with it. They don't. You want to look at cognitive impairments. Always try to speak to the patient first. Always try to get your information from the patient first. If you cannot, because of an impairment or disability, then you go to your patient caregiver or relative or something of that nature to get your information. But always start with them. Now, as far as hostile patients, most patients are more than willing to talk and want to give you information, but sometimes you will not have that. So your safety comes first. Make sure that you utilize some diffusing strategies. If somebody gets upset, you get upset with them, it's not going to help anything. So make sure that you keep that calm, reassuring tone. Don't let your body language betray any anger or nervousness that you may feel. But remember safety first, okay? Now, as far as uncommunicative patients, try your closed-ended questions first. Make sure that you go back and you really develop that rapport. Start your interview in a normal way. Attempt with the open-ended. Provide your positive feedback. Make sure they understand the questions. And then if they're still not able or willing to communicate with you, then start trying to use some of your closed-ended. Some of if you can start getting a 1 or 2 words out of them, maybe that'll kind of open the lines of communication there and get them to be able to talk to you. If there's a specific reason that they are not willing to share information with you, try to nullify that concern if you can. For instance, I've had patients who were hesitant to talk about drug use or alcohol use because they were afraid that the cops would find out. And I've had to explain to a couple of them that, I'm not the cops. I'm not here to arrest you or get you in trouble, but, what we do or don't do, your drug or alcohol use may affect it, so we need to know so that we can treat you appropriately. Always make sure that they understand that you're there for them to help them.